I'm Dr. Christopher Meyer with the Vein Academy, and would like to briefly describe how we do a radiofrequency ablation of the short saphenous vein. We begin the procedure by scanning transversely, and then we turn longitudinally over the vein at a suitable insertion site. We try to put a small amount of lidocaine in prior to putting the needle into the vein. The trick to initially inserting the needle into the vein is to use one of these green super sharp needles. We also like to waggle the needle from side to side in order to get the needle tip into the same view that we have of the vein. Other tricks are to try to distort the superficial wall of the vein with the needle, and that way you know you're in the correct frame. At this point, the needle has been inserted into the vein, and we pass a small glide wire into the vein, or small guide wire into the vein. We then remove the initial needle, and we will dilate the tract using we actually use a spinal needle to dilate the tract. There we're confirming that the wire is properly in the vein. And here we are dilating the tract with the spinal needle. After that is completed, we use the introducer sheath, which we pass over the wire and insert the introducer sheath into the vein. It's important to make sure that you have some wire coming back on the outside of the sheath prior to inserting the sheath into the vein, so you don't lose your glide wire into the vein. Here you remove the dilator and glide wire together from the sheath, and then you pass your radiofrequency ablation fiber into the sheath. These are a 3 centimeter heating element, and we'll pass this to the sapheno-popliteal junction. Sometimes it's hard to see that junction, and in those cases we'll keep the probe transverse, and right over the popliteal space we'll just make sure that the tip of the probe is within the sheath and not going deep into the popliteal vein. A lot of times that doesn't even go into the popliteal vein, but will stay superficial in the vein of Giacomini. And here we are beginning our tumescence. We have the fiber in a good position. We're adding tumescent anesthesia around the fiber, and we'll do this for the entire length of the fiber from its insertion site to the tip. One technique that seems to be more successful in getting the tumescent to stay within the sheath is to place the needle between the fiber and the superficial fascia. In this case, it's not dissecting very well, but for some reason, when the needle is between the fascia and the fiber, you get it dissects better, and leads to less need for more needle sticks. And we'll do this tumescent for the entire length of the fiber. You can see here we're going towards the tip of the fiber. Once we're at the tip of the fiber, then we'll begin treating the vein with the radiofrequency ablation catheter. Once you see the fiber disappear, you know that you're at the tip. The final part of the procedure is actually ablating the vein. The Covidian or Medtronic catheters have different hash marks along the length of the fiber. In the beginning, you'll press the button on the the radiofrequency ablation fiber for 2 20-second time periods. You want the temperature to heat up to 120 degrees Celsius in order to get adequate closure of the vein. So when you first begin, we'll hit the button twice for 2 20-second time periods, and then at that point we'll remove the sheath, and then we will pull the fiber back to the next closest hash mark, and we'll treat for another 20 seconds at that location. We'll continue treating at each hash mark until we get to the final 3 centimeter hash mark, which we'll treat twice. So each hash mark, when you first insert it, you treat twice, then you treat it once at each hash mark, and then you treat it twice at the 3 centimeter mark, and then remove the fiber. After the procedure, we recommend keeping the leg wrapped with an ACE wrap or a compression stocking for a total of 48 hours. We do allow the patients to remove the ACE wrap to shower the night of the procedure and then to rewrap it or place a compression stocking. We don't give any activity restrictions. The patients we encourage them to be as active as possible after the procedure, to walk, and if necessary, take a small amount of ibuprofen. Here we are treating at the 7 centimeter mark, so we'll do 1 20-second treatment at this level, and then we'll pull it back to the 3 centimeter mark, and then do another 2 treatments at the 3 centimeter mark, after which we will remove the catheter, and that's the completion of the procedure. The main clinical pearls in this procedure, I would say, first of all, the most difficult part is to correctly insert the needle into the vein. The important thing is to see the tip of the needle and the vein in the same frame when you're trying to insert the needle, and then also to look for that distortion of the vein by your needle tip, and make sure that you actually have your needle tip in the frame that you're looking at. Also, once you've inserted the fiber, making sure that the tip of the fiber is not going into the deep system. Here you can see that we're removing the fiber. We hold pressure for 5 to 10 seconds, and then we'll go ahead and wrap the leg with an ACE wrap. We always wrap from the toes up to the knee. Begin your wrap at the ankle, and you wrap too tight, you can get some swelling of the foot. The main reason to wrap the leg is to prevent significant ecchymosis, and also to prevent any drainage from the areas where the tumescent was injected. I'm Dr. Christopher Meyer with the Vein Academy, and this was a demonstration of a radiofrequency ablation of the short saphenous vein.